Let me tell you about a number. The number is $87,000. That is what a hospital in California billed a patient for a 3-day stay following a cardiac event. No surgery, no intensive care unit. 3 days of monitoring, medication, and observation in a standard hospital room. $87,000. Here is another number, $9,200. That is what the patient's insurance company actually paid the hospital after applying its negotiated rate, a discount of roughly 89% off the original bill. Here is a third number, $3,100. That is what the patient owed out of pocket after the insurance payment was applied. Deductibles were calculated, and the explanation of benefits arrived in the mail 3 months after the stay in an envelope the patient almost threw away because it said this is not a bill on the front. 3 numbers, same medical event. None of them related to each other in any way that a normal human being can explain. And if you called the hospital, called the insurance company, and called the state insurance commissioner trying to understand how $87,000 became $9,200 became $3,100, what you would get is a series of polite, unhelpful phone calls that collectively explain nothing while somehow making you feel like the confusion is your fault. This is the American healthcare billing system, and today we are going to explain it. Not because the explanation will fix it, but because understanding exactly how something is broken is the first step toward being appropriately angry about it. And you should be very angry about this. Let's start at the beginning, with a number that doesn't exist anywhere in reality and yet somehow controls everything. It's called the ChargeMaster rate. Every hospital in America maintains a ChargeMaster, an internal price list that assigns a dollar value to every service, procedure, supply, and room charge the hospital provides. A bandage, an aspirin, an hour in a recovery room, a blood draw, an MRI. Everything has a ChargeMaster price, and the ChargeMaster price has almost no relationship to what anything actually costs, what anyone actually pays, or what the service is actually worth. ChargeMaster rates are typically set at anywhere from 2 to 10 times the actual cost of providing the service. They are deliberately, systematically, and almost universally inflated. And for decades, hospitals were not legally required to publish them. They were internal documents, trade secrets. The price list for the most essential services a human being might ever need was confidential. It wasn't until 2021 that the Centers for Medicare and Medicaid Services finally required hospitals to publish their ChargeMaster rates online. And when they did, 2 things happened. First, the public discovered just how astronomical and arbitrary the numbers were. Second, almost nobody could actually use the information because the files were published in formats so complex, so inconsistently organized, and so deliberately difficult to navigate that consumer advocates immediately called the transparency requirement nearly meaningless in practice. So why does the ChargeMaster exist at all if nobody actually pays ChargeMaster prices? Because it is the anchor, the starting point, the fictional number from which all other numbers are negotiated. And understanding this is the key to understanding everything else about hospital billing. When an insurance company enters into a contract with a hospital network, they negotiate a discount off the ChargeMaster rate. A large insurer with millions of members has enormous negotiating leverage. They can credibly threaten to exclude a hospital from their network, which would send that hospital's patients to competitors. So they negotiate aggressively. They might get 70, 80, even 90% off the ChargeMaster rate for certain procedures. This is why your insurance company paid $9,200 on an $87,000 bill. The $87,000 was never a real number. It was a negotiating position. But here is what this system means for people without insurance, or people whose insurance company has less negotiating power, or people who receive care from an out-of-network provider they didn't choose and weren't warned about. Those people get billed at or near the ChargeMaster rate. The most vulnerable patients, the uninsured, the underinsured, the people least able to pay, are presented with the most inflated possible bill. And while hospitals are required to have financial assistance programs, navigating those programs requires knowledge, documentation, time, and persistence that many patients in medical crisis simply do not have. Now let's talk about what happens after the ChargeMaster. Because even after your insurance company has applied its negotiated discount and paid its portion, what you owe is determined by a series of overlapping calculations that seem specifically designed to be impossible to understand in advance. Your deductible, the amount you pay out of pocket before your insurance starts covering anything. In 2024, the average deductible for employer-sponsored health insurance in America was over $1,700 for an individual plan. High-deductible health plans, which now cover roughly half of all privately insured Americans, had average deductibles of over $2,500. This means for the majority of insured Americans, the first several $1,000s of medical expenses every year are paid entirely out of pocket. The insurance card in your wallet provides approximately zero financial protection until you have already spent thousands of dollars. Your copay, a fixed amount you pay per service regardless of the actual cost, your coinsurance. A percentage of the negotiated cost you pay after the deductible is met, your out-of-pocket maximum. The theoretical ceiling on what you can be asked to pay in a year, beyond which your insurance covers 100%. These numbers interact with each other in ways that are genuinely difficult to calculate even for people who understand them and are presented to patients at the moment of receiving care, when they are sick, frightened, and in no position to run spreadsheets. And then there is the phenomenon that quietly became one of the most financially devastating surprises in American healthcare, the surprise bill. Specifically, the surprise out-of-network bill. Here is how it works. You go to an in-network hospital. You have surgery performed by an in-network surgeon. Everything seems fine. And then 3 months later, you receive a bill from the anesthesiologist who was in the operating room for 45 minutes. You did not choose the anesthesiologist. You did not know who the anesthesiologist was. You were unconscious, and the anesthesiologist is out of network. So they bill you at the ChargeMaster rate. Your insurance pays out-of-network rates which are substantially lower, and you are responsible for the difference. This is called balance billing. And until the No Surprises Act was passed in 2022, it was completely legal everywhere in America and happening to millions of patients every year. The No Surprises Act was a genuine improvement. It prohibited balance billing in most emergency situations and for certain out-of-network care at in-network facilities. But the implementation has been contested by healthcare providers in court. The rules contain exceptions, and the fundamental architecture of the system that created surprise billing, the ChargeMaster, the network negotiation structure, the opacity of pricing, remains entirely intact. Now let's zoom out, because the individual billing experience, confusing and infuriating as it is actually a symptom of something larger. The American healthcare system is the most expensive in the developed world by an enormous margin. The United States spends roughly $12,000 per person per year on healthcare. Germany spends about $7,000. Canada spends about $5,400. The United Kingdom spends about $5,100, and on nearly every major health outcome, life expectancy, infant mortality, chronic disease rates, preventable death, the United States ranks below most of the countries spending half as much, more money, worse outcomes, by almost every measure. And the billing complexity is not a side effect of this system, it is a feature of it. Because the opacity serves people who benefit from opacity. Insurance companies benefit from complexity that discourages patients from challenging denials. Hospitals benefit from ChargeMaster inflation that creates room to negotiate while still generating substantial revenue. Pharmacy benefit managers, middlemen who negotiate drug prices between manufacturers, insurers, and pharmacies, and whose business model is so deliberately impenetrable that congressional hearings have struggled to explain what they actually do, benefit from a system where nobody can follow the money. Medical billing companies, claims processors, utilization review firms, and the entire administrative apparatus that has grown up around healthcare billing now accounts for roughly 30 cents of every dollar spent on healthcare in America. 30 cents out of every dollar goes not to a doctor, not to a nurse, not to equipment or medication, but to paperwork. The average American hospital employs more billing and administrative staff than clinical staff. That ratio is not an accident. Every insurance company denial requires a hospital employee to appeal it. Every negotiated rate requires contract management. Every ChargeMaster update requires coding expertise. The complexity generates employment. The employment is funded by your premiums, your deductibles, and your tax dollars. And the people employed to manage the complexity have a structural interest in maintaining it. Here is the part that should stay with you after this video ends. In 2003, a study published in the New England Journal of Medicine estimated that simplifying the American healthcare billing system to match Canadian administrative standards would save approximately $286 billion per year. In current dollars, that number is substantially higher. That is not $286 billion that would disappear. It is $286 billion that is currently being spent on administration that other countries do not spend, that generates no medical care, treats no diseases, saves no lives, and exists entirely to manage the complexity of a billing system that is complex by design. You did not design the system. You did not vote for it. You did not choose it. You navigate it at the worst moments of your life. When you are sick, when someone you love is sick, when you are frightened and overwhelmed, and the last thing you have the capacity to do is decode an explanation of benefits. And then you receive a bill you cannot understand for a service that had no posted price for a procedure, whose cost you could not have known in advance from a provider you may not have chosen, and you are given 30 days to pay or face collections. And somewhere in a building you will never visit, a team of people is making sure that next year the system is exactly this complicated. Because complicated is profitable, and profitable is the point.